Good morning, all. I am grateful to be here in front of you with this topic. All thanks to Kerala ISA, especially Dr. Biake, Sajeesh and Suneel for letting me to do this topic on management of transplanted patient, a focus on liver. I have organized my presentation into these 5 domains, starting with the major challenges. ICU pathophysiology comes as second. Third is systemic management one by one, and graft function and protection of the graft after transplant and anticipated complications after transplant. Coming to the challenges, as we all really know, these patients are very complex due to their pre-morbid altered physiology, and there is really no literature or guidelines currently to manage these type of patients. For that reason, it is really important to have a multidisciplinary team to overcome these caveats for the best outcome and remove the personal preferences. So it seems to be a team sport which requires collective rounding, discussion and decisions initiated with excellent handoff from operating room to ICU, filling all knowledge gaps between this 7-member team of consultants who will be available 24/7 inside the hospital. So going to the pathobiology of these patients, we all know there are many confounding factors for this group of patients. The big part of these factors are usually carried from their pre-op conditions, which includes altered hemodynamics, coagulation abnormalities, renal and neurocognitive and pulmonary dysfunction, so on and so forth. This basic pathobiology gets aggravated by these pre-morbid red flag factors, which should be modified for the better outcome. These confounding factors, along with the residual pathobiology, as I described earlier, leads on to most dreaded cardiorespiratory instability, resulting in graft compromise, which is unacceptable at any cost. The first thing we come across as the patient is being shifted from operating room to ICU is hemodynamic instability. As I said earlier, it is due to vasopregia, secondary to liver dysfunction, compounded by the drug use for anesthesia, analgesia, and reperfusion injury. We could look into the lactate values and the magic map goal of 65 millimeters of mercury via centrally placed arterial line, preferably femoral, supported by 65 trial and sepsis PAM trial. Coming to the volume status, the world is moving away from CVP and PAOP to PICO and its various dynamic indices. We do many echocardiography, preferably TEE, to get a balance between fluid resuscitation and vasopressor requirements, preferably noradrenaline, to maintain an end organ perfusion. When we think of fluid resuscitation, we must think of hemodynamic instability due to hypovolemia. This hypovolemia is corrected using balanced salt solution Baseline, sticking on to less is more strategy supported by the BASICS trial. This hypovolemia may result in renal failure like HRS and AKI. It might also be due to the pre-existing illness, surgical insult, reperfusion injury, all plays an important role, which could be monitored using rising BUN and creatinine values and falling urine output. This AKI is managed by avoiding congestion by using diuretics, maintaining a MAP of more than 65 and urine output of more than 0.5 ml per kg per minute. And early CRRT coupled with a judicious use of diuretics is also called push and pull therapy, and avoid nephrotoxic drugs. If you combine early CRRT with the judicious use of diuretics, it is It is called push-pull therapy. It is not supported by the START and Akiki trial. Coming to the bleeding and coagulopathy due to these factors like significant venous collaterals due to the opening up of various shunts and due to the infections and previous surgeries, pre-existing coagulopathy, dilutional coagulopathy, and post-transplant liver dysfunction might extend to the post-operative period and makes them bleed profusely. Coming to the management part of the coagulopathy, we follow restrictive transfusion protocol, limiting the use of blood components to get a balance between thrombosis and bleeding in order to prevent hepatic artery and portal vein thrombosis. We do look at the drain output, melena, rising burn and falling hemoglobin. We usually don't look into the absolute numbers of coagulation profile, but we do correct as per the TEG values, supported by TRIC and TRIS trial. Coming to the neurocognitive dysfunction, otherwise called as hepatic encephalopathy, are very common, may be caused by high ammonia and residual effects of anesthetic and analgesic agents, or could be due to electrolyte imbalance, or may be due to calcineurin toxicity as an immunosuppressant. To counter this, we need to tailor our sedation and analgesia as per the GCS and RAS scoring and stick on to the short-acting opioids like fentanyl, remifentanil, dexmedetomidine, propofol, coupled with the early mobilization, make sure that there is no benzodiazepines are administered, which will worsen the delirium. Coming to the pulmonary dysfunction, which could be hepatopulmonary shunt or syndrome or portopulmonary syndrome, usually present as hydrothorax, ARDS, and TRALI due to multiple transfusion. In big part, the PO2 will be less than 50. We usually tackle it with the lung protective ventilation, 6 ml per kg, below 6 ml per kg, and PEEP of less than 10, and application of bundled care to prevent the VAP and early liberation from the ventilator, minimizing the use of neuromuscular blocking agent. Considering the malnutrition and deconditioning of the muscle, which are very common due to decreased intake during pre-morbid phase, which can be countered by early initiation of feed within 12 hours, preferably enteral. Parenteral could also be used. Hold the feed if there is any shock and should be volume-based and should provide 25 to 30 kilocalories per kg of calories and 1.5 to 2 grams per kg of proteins. These are all supported by Eden and EPANIC trial. Coming to the last part of the presentation, lastly, the infection, which could be donor or recipient derived, common and lethal. The sources may be from the blood, that is BSI, or maybe from the lung VAP or gut translocation. We should continue infection control practices. Antimicrobial should be initiated as per the antibiogram. There is no role for prophylactic antibiotic. Considers ESPL and CRE coverage in high-risk patients. Surgical, CMV, and pneumocystis jirovecii prophylaxis in high-risk patients. Coming to the anticipated complications like hepatic artery thrombosis, pulmonary vein thrombosis, portal vein thrombosis, hepatic vein thrombosis, biliary complications, and rejection, and so on. The graft assessment and protection should be done by sending transaminases, bilirubin, GGT, and coagulation profiles. Worsening burn and creatinine also gives us an idea about the graft assessment. T liver Doppler and CT angiography confirms the graft assessment procedure and could be managed with a surgical IR technique in the case of hepatic artery thrombosis, NAC4, N-acetylcysteine for reperfusion injury, immunosuppressants in rejection, and sometimes it may end up in renal transplant. The take-home message is follow enhanced recovery after surgery protocol in this type of surgery as well. PICO and dynamic indices for monitoring. Less is more strategy for transfusion as well as fluid therapy. Antibiotics as and when required. No role for prophylactic antibiotic or antifungal. Immunosuppression of choice. One size doesn't fit all. Early nutrition and mobilization for the reconditioning of the muscles and liberation from the ventilator. Thank you for taking care of me.